Hi, I'm the educational consultant with Advanced Nurses at ACD4N. And today I have somebody really special with me. She is actually a direct care worker. She has been working with children with at-risk children for, I would probably say at least 15 years now. And she's worked in multiple capacities. She is, again, as a direct care worker, she has worked in a capacity where she has worked in more of the transportation setting. It's like accompanying a child with developmental issues, and then also more extensively, more of her background actually is in working at residential and in patient psych facilities, again working with this population, primarily children, but some work with adults. And so my experience, I have worked with adults and children with mental health and other psychosocial issues, and I can't say that I was not prepared as a nurse working with this population, because prior to becoming a nurse, I was working in this population in a classroom setting as a therapeutic staff support. And so essentially that role looked like being in the classroom with at-risk children, and even in some cases working in after-school programs, helping their family kind of bridge the gap between what was going on in the home and then what's going on in the home, and then also school, and then back to home in some cases, like within the after-school program, assisting even the educators and the counselors in that after-school program with kind of being that support system and helping that child develop those pro-social skills. So with all that said, there is a lot of, with all that said, there's a lot of training that goes into, like, for example, like trauma informed training. There's a lot of training around, having therapeutic communication and just kind of having the kind of patience and understanding of the psychosocial needs of individuals who are considered at risk or high risk. However, we are going to be talking today about the savior complex. I'm learning about this more and more, especially as I look deeper into issues around burnout. I see burnout being an issue for nurses. I see it being an issue for whether they're nurse practitioners or PAs, physicians, direct care workers, CNAs. I find that for the most part, as long as you are working directly in a service-like role where you're working directly with the client, directly with the patient, directly with the member, I find that this tendency is there. So it could be you developing this issue with savior complex, or it could be you being over this, right? Maybe you've gone through enough training and you kind of know where to set those boundaries, and you're working with other people who are probably kind of like new to this population, and they're dealing with some savior complex issues. Now, I don't want to go any further without allowing my guest, Faith, to talk about her experience. So can you first tell me, like, what has been your experience with, like, the savior complex working with at-risk youth?
I think first and foremost, boundaries is always an issue. When you're working with children, it's very important that you develop and exercise boundaries. For reasons you want it, that allows them to have the best care, the safest care, and also allow your I would say your peers, or to look at it as the team, because usually in mental health and behavioral health and psych, we take care of people in teams. So it gives your team opportunity to take care of the client, or if we call the individual, the best way. And because it's a team of us getting together, so we have our therapist, we have the doctor, we have the residential facility or the foster care, or we have the facility going home, like, planning and goal planning. So I think it's very important to work as a team. I think sometimes it's hard when you're taking care of people you have to exercise boundaries. It's hard when you're taking care of people. Sometimes your heart gets into it. You get emotionally attached. And like you said, a good point that you said about training, a lot of training is very important to create those boundaries. That's why it's very important that you have quarterly training. And it's very important that you participate in a lot of training. And as new things develop on the market, you should really take the time to take advantage of these things. I know that one of the organizations that I worked for, they it's called their university, their online university, and they allow you to get a certain amount of credits, and or like in an I guess nurses, they call CCUs, a certain amount of training that you have to, that is required, 40 hours of training. And they give you an option, and it could be from cultural sensitivity to just communication to like DBT, like you said, the skills, cognitive, what is it, trauma skills, like, knowing how to deal with people when they've had past traumas and not to trigger them. And I think the training, boundaries and training is very important to have a balance, because it's hard not to become attached when you're taking care of people. And of course, I would shout it to the top in taking care of people in any capacity. Self-care is important. When you are caring for yourself outside of work, when you're caring for yourself outside of your profession, outside of your accomplishment, those things are so important. Self-care is so important. You make it better to show up to work, for the team to show up to work with you. So self-care is very important, and it's, you can know when you're at that burnout button. I think people say, it could be just saying it. People say you, with every job, you have a 7-year, especially in healthcare, you have 7 years, and you may need to change things up a little bit. Doesn't mean leave out the profession, but maybe do things in a different capacity. And especially as we get older and technology expands, there's so much different ways that we can take advantage of taking care of people, and so much skills that we've learned, that we can expand our skills and our skill set. So I think definitely boundaries, training, and self-care.
Wow, you know what? You said so many great things. And I typically get excited when I'm speaking with someone. I'll jump in real quick and just, throw my 2 cents. It's kind of encourage them to go on. But I just had to take in everything you were saying, because I know that it's coming from a place where you've worked with these individuals, and you know the importance of, like you said, the training, the self-care, and those boundaries. And if I want to just go ahead and expound on those 3 points, namely about the training, I think oftentimes what happens is there's an assumption that if you're working in healthcare, that a part of you working in healthcare is that you already kind of know how to deal with difficult patients. And there's an assumption that not only you know how to deal with difficult patients, you know how to manage a team on how to deal with difficult patients. And I would argue that if you have never worked in behavioral health, or if you think that you can just tap onto 1 or 2 difficult clients you had and you can just use that and multiply that across all difficult patients, I think that is naive, right? Because oftentimes when you're working in these environments, especially with the type of training that's usually very specific to the needs of these individuals, you realize that there's a lot going on in those individuals, in their heads and in their lives and with their families. And I think in healthcare, it can get really tricky, because sometimes we think that we know the best thing. And we think that the best thing that we know, all we have to do is sell it to the patient and they'll get into it and they'll change their behavior. And oftentimes what we find is, even when we exhaust every single resource, all of our, connections, and then that person falls back down, it's like, again, going back to the title of, or the subject for this discussion here, the savior complex, you're like, at the next time I'm going to up the ante. The next time I have an opportunity, I'm going to stay 1 hour longer. I'm going to dedicate one extra day to this cause, and not really thinking about the fact that it's like a part of that training is really understanding the complexity that you're dealing with. How difficult the population is, how difficult their needs are, and being realistic about that it's not a band-aid type of thing. And so therefore, unless you really have the 1 million resources that they really need, you have to be realistic about what it is that you can actually extend to them. I've worked at places before, again, going to boundaries, where we had different things that we could offer. It could be anything from gift cards to incentives for participating in certain activities like health, seeking activities, going to doctor's appointments, or, going to certain screenings. And what I would find oftentimes is that you would not get the patient to understand the importance of them actually adhering to the visit. Their focus would be on the gift card or the incentive. And for me, I look at that and I think to myself, are you changing the patient's behavior if every time you give them a reward, you just happen to get what you need to get out of the situation, but really their focus was just the reward? And so again, about setting those boundaries, I find that if you don't set those boundaries early and you don't stick to them, you may find that the thing that they actually need for themselves, which is a behavior change, they need to think about their medical issues and their mental health and their behavioral health issues differently. And if you don't set the right boundaries and you don't provide the right education, you may have yourself someone who thinks that you're obligated to give them treats, and they're not even focused on the behavior change. This would be no different than working with like little children. I've worked with little children before, and that was always very tricky, where we would give rewards out. I worked with children like really, really little, I'm talking about as young as like 4 or 5 years old. And with that, sometimes there was a fine line when we would give them like rewards for their good behavior, because some of the children were so stuck on getting that, whatever that thing was, whether it was playtime or an extra snack or something like that. And because we were working within a capacity to change behaviors, and I was working as a nurse, but this was a place where people left their children with behavioral health issues there, and the children stayed there. They slept there, they got medications there, they were getting treatment there. And oftentimes, just with looking at those little children, sometimes you just want to give them the extra graham cracker. You want to give them the milk. You want to give them the candy that they're asking for. And when you can't give that to them, or you shouldn't give it to them, you're preparing yourself for that letdown that may actually escalate to an incident where now this child needs to be either given, a dose of medication that's an intervention to better control their behavior, or that child has to be, and I hate to use this word, maybe restrained to a certain degree. And we don't really use a lot of restraints with children. So a lot of times what we'll do, we call them therapeutic holds, where you are preventing the child from escalating that to the extent where they can harm themselves and others. And so sometimes boundaries are really hard to set with little children. I think the same is the case for adults, especially adults who are very vulnerable with like significant like psychosocial issues or maybe drug and alcohol issues. And then the concern then is kind of like, well, if I want this person to come in for their doctor's appointment, but I know they're hard up for a few dollars, they're short a few dollars, let's bring them in and give them this treat, this money, or give them whatever. And then you give them that thing to bring them in, and they come in and you get to do whatever you want to do with them. But at that moment, at that very moment when they're there, the only thing they want is that thing. They're not making real commitments to their medication. They're not really making real commitments to being, adhering to their doctor's appointments. You got them in there because of a treat you offered. And so,
If you don't
again,
mind,
what you were saying about setting boundaries is so important.
I wanted to interject because as you were talking, I was thinking that um, when you at first introduced me, I was thinking that because I had years, I was thinking of my introduction to mental health and to behavioral and that side of healthcare. A lot of times, as I get older and I present myself, in settings of um, farthering or advancing my work history, I always explain that I've done medical side of healthcare as far as bedside, working as an EMT, working as a CNA. And it is a little different when you're now in the setting of either residential outpatient or inpatient drug and alcohol, or someone seeking therapy or mandatory therapy, for school, or you're dealing with someone. So my introduction for behavioral health and psych was through children. So I wanted to say that, and the reason why is when you were saying about there's a good, there's a, it's called The Elephant and the Rider. And it's a good book, and it's also a good analogy, because it's about motivated, and it's very important to motivate when it comes into what I've learned starting off my career in mental health with children, that the motivation was very important because you're in a hospital and your goal is to get the person better, shorten the time that they're there, and shorten the time of any reoccurring issues, and try to detect whatever you can and diagnose and make the person feel better, get better. The goal is to get you better and get you moving. With mental health sometimes, and with behavioral and psych, it's a long journey with trauma, and it's a long journey of impact and unpacking things. So sometimes unpacking things could be like when we were doing trauma narratives, those things could trigger and open up a different can of worms, or sometimes you hit a wall and it's like, this is it. And you have to work from that wall and say, this is the decision that, because a lot of times when you're unpacking, now the root cause. And a lot of times working with children, a lot of times it's the first time they're hearing these diagnoses. It's the first time they're on medication, especially if they're coming from, you're dealing with substance abuse, or you're dealing with someone who's using street drugs, or you may use that someone may have been exposed to street drugs, or they're coming from an environment where it's nature nurture, like this is what they're exposed to. So this is the first time they're ever hearing that I'm addicted to nicotine. Oh, okay, and I can wear a nicotine patch? Or they're hearing the first time that someone is giving them an option if they take their medication or not. Like, it's your choice if you take it or not. It's your choice if you see therapy or not. And the thing about it is, because you have these choices in the state that I live in, you have to motivate. Got to be a motivation there. Like you gave the example of the person trying to get them to do trying to get them to take their medication and follow through with their treatment. A lot of times when you're working with adolescents, they're so new to it. This is the first time they ever heard of anything. Like, I'm angry. I thought I was just mad. I thought I just, they didn't, this is the first time they're seeing the root of their behaviors, or some of these diagnoses, or they're bipolar, that, because you have a street term that, people would say, oh, she's schizoid, or she's bipolar. And it's like, it's the first time a therapist actually breaks down to you that, no, that's not what's going on here. You're manic and you're depressed. Sometimes you're very sad. Sometimes you have this burst of energy, and someone breaking it down. And like what you said, about communication, breaking it down in layman's terms so the person can kind of understand, and sometimes using some kind of urban or street lingo, or using cultural communication that may communicate to another population. You may not want to say words or do things that would be offensive to them in saying these words, but you want to break down, because a lot of times, sometimes people have a wrong definition of what things are. So a lot of times with children, it's new to them. Now with adults, sometimes they're used to being in settings. Sometimes it's a part of their requirement because of legal issues that they have to be in these settings. So you may get them to cooperate a little bit more. It's not the first time that they heard, I hear voices in my head. Okay, well, and the proper definition for what that is, and okay, so when I take my medication, those voices stop. As you get older, you can better understand it. So sometimes it's easier to take care of, or maybe you have more of a success rate when taking care of adults, like, but I think with everything, I believe in the method of motivation. I believe in offering, I believe in motivation, and I believe in a reward system. I think it works. I don't believe that you reward bad behavior, but you do reward progress. You reward progress. When someone shows up to a meeting, maybe they're not comfortable. You don't know what's the reason why they're not comfortable in a group setting. You don't know if that's the most effective therapy for them. But I want to encourage you to come back. So maybe my encouragement is coffee, and we want to have coffee and donuts today, or something, or I'll get that creamer that you really like. And it's not to manipulate the person, but it's to motivate them into therapy, motivating them to show up, motivating them to participate. Maybe next time, oh, what kind of, do you like a certain dessert or a certain candy, or is there something that, is there a soda that you like, or something like that, or maybe a movie that you would like, because we realize that sometimes therapy is difficult. It's difficult. Sometimes people show up 100%, and they're ready to go, they're ready to get in, and whatever comes along with it comes along with it. And then for some people, because it's new, or sometimes it's unearthing certain things, you got to know how to, work with people as they present. Just working with them, allowing them to express themselves, allowing them to be comfortable, and knowing when, okay, we've done a lot today. We've covered a lot today. Is there something that you would like to cover? Is there something that we missed today? Inviting that person into that therapeutic space, because we don't want to stray too much from our topic, but I noticed that because I started off working with children, I noticed that a lot of times I wanted to save them, and the environment wasn't conducive of that. Because when you're there, and the first time you see, a child, I'm just going to use bedwetting, for instance, as a teenager, and it's hard. It's because you're like, okay, what can I do to make this, to give you your dignity, to give you your respect, to let you know that this is not your fault. It's not something that you did. Could it be because you're in a new environment? Could it be a dream that you had last night? Is this something? And we want to go and we want to work with the team. And a lot of times, if you feel coming from a medical background, doing bedside care, assisting doctors and nurses in step down, surgical step down, critical care, ICU, emergency room setting, I want to answer the problem. That's just me. I want to answer the problem, because that's how, when you're coming from working in a hospital, your job is to answer the problem. Your job is not to, your job is to go in, know what's going on, and answer. When it comes on to mental health, you have to kind of invite that person into the care. So therefore, it's like, got to be patient, invite them. The answer would be just wear a diaper at night. Well, it's a teenager, a 17-year-old. I don't think, and maybe they're in a residential setting, maybe they're at home, maybe they share a room with a sibling. Maybe that's not going to be the answer. If they're in a hospital, you can say, well, our protocol is that we, turn you every 2 hours. We want the integrity of your skin to stay intact. So we want to treat that. And, we can give that spiel to them and let them know why we're doing it, because they're not here for bedwetting. It's just sometimes that's something that they're dealing with while they're in the hospital. But when you're doing residential, or maybe someone at home, you're sending them at home, and that may be a concern of them. They're a teenager, they have dignity, they have respect. You have to still give that to them. Now we have to work with what things can we do as far as, maybe not drinking at night, or is this medication what's causing that, or is it something and we work as a team. So that helped me when I realized the role of everyone in the team, from the psychiatrist, to the psychologist, to the doctor, to the social worker, to the case management. Once I realized what their role was, my savior complex, I was able to say, can't do this. We have to work together as a team.
I'm so glad you said this, because, and I'm glad you had listed out the different players in the team, because oftentimes when you're working in the capacity of a individual with, as a professional working with individuals who are high risk or at risk, you can really, especially if you are a pragmatic thinker, you're kind of, you think about things in a context of solving problems, and you're very solution oriented, you could start really pulling things out your hat. Like, you know what, I noticed that person really brightened up when I asked them about you know, their high school days. Or I remember when I asked them about their favorite color, I noticed that they were really engaged. Let's tap into that. And sometimes, because of the experimental approaches, often because the complexity of mental health and psychosocial issues, it's so complicated. I think that sometimes we actually think that we have the answer, right? And sometimes we think we have the answer and nobody else has the answer, and we think that we made that special connection. And so therefore that savior complex comes in even more so when you're kind of operating kind of siloed off, right? So that you kind of think to yourself like, okay, like I have, this special touch, I have this special way of thinking, I have this magic, this magic that I'm going to share, and it worked for this other person, so it should work here. And so we're so experimental when it comes to behavioral health and mental health issues. I think sometimes we think that we have all the answers, and we don't think about the fact that the psychologist is coming from their paradigm, the social worker is coming from their paradigm, the nurse, the case manager, the direct care worker, the behavioral health tech. Everybody is coming from a different working relationship with the patient, or even just mindset as far as their profession and the scope of their work. And I think that that's also what leads to burnout, and also a false sense of being able to save the patients, because of the fact that, it's so tempting that we think that we are the psychologist, we are the therapist, we have that answer for them, because it's like, we know that dealing with a medical issue, let's say if a person has hypertension, we have very specific pills, very specific treatments and therapies that will lower the blood pressure. And so we tend to look at those remedies as the thing that we want to go to, and we're not going to deviate too much to the right or left, right? Maybe we will take a little advice about an herbal tea here and there, but for the most part, if you have that hypertension diagnosis, you're going to go for those hypertensive medications that works, right? And we're going to stick with those. Seems like when it gets to behavioral health and mental health, people think that they're just like, it's just the way they ended their sentence, or it's the way they laughed and smiled with that client, that really is the thing that's the most therapeutic intervention for that patient. And oftentimes we create this world in our own mind that we have solved these problems, right? And that we should not rely on very, evidence-based approaches. Again, like I was saying, if somebody has hypertension, we go for evidence-based remedies. These are the remedies that work with someone who's about your age, about your height and weight, with similar medical background. And this is how we're going to treat this hypertension. For some reason, I find that when we're talking about behavioral health and mental health, people think that they could just take a rabbit out of the hat, and they're like, you know what? I like the way he smiled. I like the way she smiled when I took this rabbit out of my hat. Boom, problem solved. And then when that person has a relapse, or that person doesn't respond to that treatment, that intervention is not as effective, we start thinking that we're going to pull the trick out of, pull the white, the white bunny out of the hat, and get that fuzzy feeling from that patient. And, that patient is like, no, I'm back to relapsing. There's nothing better than the high that I get from this particular drug. And so I find that that's where I think a lot of burnout happens as well, where we are not being honest with ourselves about how much we can give and what too much is looking like, especially when we're dealing with a lot of patients. It's one thing when you have one patient that you're dealing with, or two difficult patients, but when you're working in at-risk populations, everybody is at risk. Everybody is deemed. You don't have a short list of people who are like, oh, these people just need some extra time. No, all of these people are presenting with this problem. So therefore, we need tried and true methods that we can really pull on, and we need a team of individuals who are not thinking like, let's pull a rabbit out of our hat, but no, let every single individual. That's what a multidisciplinary team means. It means that yes, we are convening and we are in agreement of a singular principle, but the multidisciplinary part of it is I'm not going to be, as a nurse, pretending that I'm a psychologist. As a nurse, I'm not going to pretend that I'm a behavioral health tech. As a behavioral health tech, I'm not going to pretend I'm a therapist. As a therapist, I'm not going to pretend I'm a psychologist. As a psychologist, I'm not going to pretend I'm a behavioral health tech, because the multidisciplinary approach is really leaning into the idea that everybody's going to have their approach, and we're going to see when we put all these different seasonings, all these different approaches together, what the outcome is and which one of these things work. And we also know that sometimes these things work for the situational piece. Sometimes it's a situational thing, and it works when all of those things, all of those factors in a situation are present. But all you need is one of those factors to not be present, and all of a sudden it doesn't work, right? So I've seen situations where if I'm pulling in a family member and they're involved in the plan of care, smooth, everything is fine. You can get that person to go along with anything because the family member is involved. But then you pull that family member out of the equation, they pass away, they move, or they're exhausted. They're like, listen, I got my own medical issues. I can't take care of such a one anymore. When that patient is on their own, that member's on their own, that child, that adult is on their own, and they don't have that social support, a lot of those other interventions that used to work now don't work, because from a situational standpoint, the factor has changed. Those factors have changed. So now the situation has changed. Now we're talking about a fatherless patient, or a patient dealing with abandonment, or a patient now who's relapsed because the mother or father was the person who kind of kept them off the streets. Now we're dealing with a substance, or let's say even worse, a new substance. Maybe before it was just alcohol or marijuana, and now this person has said, I start using fentanyl now because in the absence of my father, the fentanyl is what really helps me deal with this stuff emotionally. So I find that if we're not careful, we may think that we have those tricks, and when they don't work, then we fall down a bit, and we take it hard as those professionals who we've invested so much of our time and our resources to solving these problems, and thinking that we have that magic touch. No one would think about hypertension that way. I would never think that I had a magic candy that would fix somebody's hypertension. I would know that I would be using evidence-based medicine, evidence-based approaches to take care of that hypertension. I don't know why we think that when it comes to behavioral health and mental health issues, that we can just exhaust ourselves with all these different creative options, and expect to have, a specific outcome.
I think one thing that worked out well was training together when we were saying that. And it allows you to see, and sometimes when I was able to, I sat in some of the groups, some of the therapeutic groups, and I found that I realized it worked. I realized it worked. It's just not like, oh, all right, so this is a break during the day where, because a lot of my introduction, like I said, was for residential care. So a lot of it was like, okay, well, this is a break that the frontline staff or the direct care staff, they're going to their therapist for an hour. And I find that when I was able to sit in some of the groups, and that's when I learned about DBT and different trainings or different approaches that they were taking, and we could now adapt some of those approaches. We didn't just leave it in that therapeutic group. Maybe we can use this at dinner time. Maybe we can use this at meal time. Maybe we can use this at the shower time, or when we're playing a game or doing an activity. Maybe we can use this sanctuary, or use different when there's a situation that occurs, maybe a fight or something breaks out, or someone's dealing with the loss. Because we don't sometimes take into consideration that someone, like you said, someone could be totally into treatment, and all of a sudden something comes up. I've taken care of children before, and oh, my father passed, or they're there, and all of a sudden my brothers passed, or one of the things that, because it was children, we didn't allow them to watch the news. Sometimes the news would trigger them, hearing different stories or stories about their neighborhood, and they're away. It would trigger them, like, oh, that happened on my block, or so those type of things. I think that it's very important, like you said. I think in training, it's very important that we sometimes train together, doing reenactment, what it looks like when they leave out of the social worker's office, and maybe they had their heart. They did everything they needed to do in the residential piece. They did everything they needed to do in the therapeutic piece. We go to the social worker, and we find out that sent DHS out to the house, and the beds are gone. And it's been things like this have happened on several different occasions. Send everything, they've done everything that they needed to do. The mom does everything she needs to do on her, or father, or family, the eucharist of the family, the foster care, they do everything they need to do. We just can't get you to stop fighting. So therefore, we don't know how your behavior, or we took your did a drug UDA, UDS, and we find that there's marijuana. How are you getting a hold of this? And when you get out there, are you going to be, if you're able to get a hold of drugs while being here, what happens when you're out there and I'm not there to redirect you? So those things are there when you look at every piece, because it's a team that helps that savior complex. So you're not looking at, oh, okay, maybe the doctor has the final say, but we're going to bring the residential in. And that's why treatment team and team group, those things are very important to kind of taking the wind out of that, because it's like, okay, well, are we able to, and when you're operating in good boundaries, are they meeting the needs of the social worker? Are they meeting the needs of the education piece? Are they meeting the needs of the therapist? They're meeting the needs, even nutrition. Because when you were talking, I thought about when you're talking about blood, someone treating someone with high blood pressure, hypertension, I thought about someone with an eating disorder, those things. So I think the piece of us working together as a team really quells that savior complex. And because when you see the valuable work that the therapist is doing, the work that the parent is doing, and when we see someone falling maybe by the wayside, because a lot of times in all of that, in my personal opinion, I look at the social worker and the case management sometimes as having some of the heavier lifting to do. Because you're not directly dealing with anyone. Your caseload tends to be a little heavier, so you have to know, what is my breaking point? When do I raise my hand and say, I've had enough today? Or I'm not taking anything home on the weekend. A lot of times they put those people, because of their degree or expertise, they put those people in management positions too. And sometimes when they're in management positions, it tends to be overwhelming, and they're used to being dumped on. So one environment that I worked in, they every weekend they kind of rotated the on-call position. So the on-call, sometimes the case manager would have it, lead case manager, sometimes lead therapist, sometimes a doctor would be on call, sometimes our clinical manager would be on call, our director, and it depends on who you were calling, basically, is the feedback you're going to get on certain things. If the person doesn't really know that resident in particular, at reaching out to them, you have to kind of give more of a build-up. This person, give a whole, reading out their whole chart in order to get, this person's family member wants to come see you. Is there anything that in particular that would prevent this pop-up visit from happening? Is there any restrictions that we need to be mindful of? Are we allowed to leave them in one of the conference rooms alone, or that kind of thing? So I think working together as a team, communication is such a key thing, and knowing everyone's role. So this way you can respect everyone's role. And like I said, maybe for I've had a therapist that stepped into the position of the director. And when he came over to residential, he was like, this is what residential is. And he had, he was one of those therapists that kind of was in his bubble. He did his work and did what, his therapeutic interventions and care. And he was an excellent therapist. Sometimes at residential, we would be like, I know you didn't just do that. I know, like we would question some of the things that he would do. And I think one thing in particular was, we thought he was very transparent with his clients and trying to get them to work towards goals. So he would let them know, you did this to such and such. So some of the incident reports, some of the documentation wasn't kind of disclosed. So when the person, at, like say 9 to 5, at 5 o'clock, the person is now having a full outburst. Like, yeah, my therapist told me what she said, and blah, blah, blah. I'm like, well, it's a part of my protocol to document everything that is done within that time or this event, whatever. So, however, when that therapist now became a director or coordinator, he kind of thought of like, oh my God, look at all those times that I did that to them. Oh, you're really left out of here on your own as a residential direct care. staff. So it depends. I think it's very important for us to know each other's role. Like I said, I think that the case manager and the social work, I think it's so hefty of a bag to take on, and there's so you're tiptoeing, you're going out into people's personal space. You got to go out to their household. You find things about them that maybe other people didn't know. You're coming into their personal space. You're the person that's going to report back, is this a good environment for this person to be in? And you kind of making that decision, so that I thought that was kind of heavy. It's kind of weighing. I thought it was a very big part of so those people, I felt like checking in on them a lot of times, seeing how they're doing, seeing what's going on. I've had therapists create boundaries, like, if you're not coming to my office, with their client, if you're not coming to my office with something productive, or you're not saying anything that is productive or kind about staff or about the facility, you can't just pop up. It has to be a schedule. And she would leave her door open. She would leave her door open. And it wasn't like, some therapists close their door, make that rule and then close their door. She left it open to try to test that boundary, like so she can let them know, I'm standing firm on you coming here and bringing nonsense to me or deflecting, and then on the same hand, like I said, that there's other therapists that was overwhelmed when they went to residential. It was too much for them, like dealing with someone directly in that way, and you're everything to them. You're everything. When everything is said and done, you're everything to them. So it wasn't, and maybe that person is new in their treatment, so maybe that person struggles with communication. So then, you had to, I think that at those times, everyone sees each other's role. And I thought it was very important that he saw that role, that de-escalation is very important. Sometimes you have to use that plan to be silent. Sometimes you have to let the person manifest. Whereas though, someone else in a different role would be like, you can't talk like this in my office. You can't be like this in my office. You can't use profanity in here. Sometimes when you're dealing with someone directly, you allow them to communicate the way that they communicate. So it's about respecting each other, respecting the group, respecting the team, knowing each other's roles, and being sensitive to, this is what this person presents, and being respectful.
You said so many great things, and I just want to just highlight some of the things you were talking about, because again, this conversation is not just about identifying these problems, but it's also about looking at ways that we can overcome savior complex, right? So like you said before, setting boundaries. So learning when to say no and to prioritize your own well-being without feeling ashamed, right? Or feeling shame. Also self-care, to ensure that you're taking care of your physical and mental health. I have watched this and I've observed it as a huge red flag if I am being trained or oriented by someone who I don't see taking breaks. I don't see them going to the bathroom. I don't see them promoting for me to take breaks and go to the bathroom. I don't see them taking a lunch. If I'm shadowing them, they've spent the whole day and they're not even looking at me like, are you hungry? When I watch that, all red flags for me. This is probably not a person who's a good role model for self-care, or probably for setting those boundaries. Also, seek support, engage in therapy and counseling to address underlying issues. There may be issues with your savior complex because you experience a bit of transference, where some of the patient's own and that member's own behaviors is kind of some of that is internalized, right? You're taking some of that in, and so therefore it could be triggering for you, and therefore that savior complex is almost your own way of dealing with some of your own hurt and trauma. And also reflect on your motivations. I heard you saying that too, and I thought that was really important. Understand why you feel compelled to help, and whether it is healthy for you and those who are helping. I don't think people really understand. You could have great intentions to help somebody, but at the time where you're helping them, it actually isn't the best thing for them. And it's also creating a bad situation for you, because now you've created a dependency where that person, instead of putting their hands on the steering wheel of their health, you've put your hands on the steering wheel, and now you feel like if you let go, you're letting go on that patient as well. So I think, it's a balancing act, right? So, balancing the desire to help with maintaining personal well being is crucial. It is important to remember that you can't pour from an empty cup. Taking care of yourself enables you to be more effective in helping others, right? So, the question is really, how do you currently manage the stress and emotional demands of your work? You have to have a strategy for that. And if that's something that you have never considered, I would argue that, especially if you're in healthcare, mental health, we're in a time right now. Currently, we are in what has been identified as a recession, arguably since probably after the pandemic, maybe even before the pandemic. There's a lot of reasons why people are dealing with mental health issues. And I'm talking about people who are employed and are in these, well, high earning positions and highly desired positions, to those individuals who've been maybe unemployed since the pandemic, right? And so we're talking about at least 4 or 5 years of people just dealing with an immense amount of stress. And this is, forget about those individuals who had childhood traumas, and all of these events just re-trigger a lot of their issues. So again, as professionals, we are just like the patients we take care of. And the question is, how do you currently manage the stress and emotional demands of your work? How do you do that?
And like you
How do you
said, that
Mhm.
to piggyback with that self-care, it's such an important piece. And you may look at what someone else is doing and it may seem challenging, or sometimes it doesn't seem challenging. My one of my the person that trained me to become a mental health residential supervisor, he was a football coach, and I could never stop singing his praises. And he always looked at things in that through that lens. And I think one thing is very important, like how teams play. There's a time that you go on the bench, you sit down and you huddle up, and you refresh yourself. And when you said about someone who doesn't take a break, I said it's very telling when someone enters the room and they're going to speak to you, and they don't even have I mean, for whatever reason, even if it's a small bottle of water, something that when they're talking over time that they would sip on something to just you know because your mouth becomes dry, and those are things that you look into. And it's not like you're judging the person or criticizing the person because of that. It's, did they care enough to do that, or did they care enough to present to you the right way? I'm particular about people talking while eating in a setting. So I think that there should be, and I understand that we rush time along. A lot of times we're trying to cram a lot of information in a small space of time. I think it's very important, but we can think of we have to think of innovative ways, creative ways to bring training along, to make it be effective. If we're doing a large group, we're doing a small group. Sometimes my last training that I was in, one of the trainers, she just did something small, like, I'm going to take 5 minutes. I'm going to turn down the lights low. And I just want us to breathe, before, like in the middle of the day, something like, sometime just to bring, because sometimes it's overwhelming, just a lot of information being bombarded at one time. Someone may be moving at a different pace than the other. And the training is very important, because we do understand the corporate structure. You got to get a certain amount of training, got to get a certain amount of hours in, but we don't know what that person's lifestyle when they leave here. Their lifestyle, maybe, I got to go pick up my kid. I'm in the middle of a divorce right now. So, we're fighting over picking up the kids from school. I have to be here on Tuesday to pick them up at 3 o'clock, and she has to, so all those things we take into consideration. People could be going through health issues. I think a lot of times with mental health, when we're serving a certain community, even in healthcare altogether, we sometimes neglect the factors of that we're human. And we've taken the oath, we've taken on to do this job. A lot of us, this is what we've always wanted to do. We take care of people. It's what we do. We take care of people in every capacity. If we're not doing it in one capacity of healthcare, we'll do it in another capacity of healthcare. We're good at it. We just have to remember to take care of ourselves, because it spills over. Like you said, that empty cup syndrome, it'll spill over in the environment. And then after a while, people can see you. People can see it. And a lot of times we come to A therapist did an analogy of coming to the water cooler, and they're sitting there talking about people's personality, and they say, Bob comes in and he's a very nasty mood, but I noticed that at 12 o'clock, Bob is not as, cranky, and someone is saying, well, could it be me? Is it me in the morning? Or, and the therapist says, no, it's not you. It's their person's stuff. And she used the word shit. It's that person's shit. You can't get involved with their stuff. Like, you don't know what that person's bringing to work. You don't know what environment that person is leaving from. It's not your job to cater to them. It's your job just to do your job. Now you can check in and ask someone, how are you doing? What's going on? Is everything okay? Do I think that I should walk up to someone every day and ask them that? No, that's not my job. It's not my responsibility. I have my own thing. If I see that there's a change in behavior, a change in communication, and change of something that you're doing, I'm not prying in your business, just checking in. Want to see everything is okay? All right. And maybe give that person avenues. Maybe you're not, I don't want the person calling me every day, dumping on me, telling me their whole life story. But maybe you can offer something or offer an outlet. You ever go to these bathrooms and they're, giving information for battered women? You'll just see a business card or a card saying, you can call this number or call that number, and it's subtle ways of letting people know that you will be there for them. It's subtle ways of letting people know that you hear them, you see them, they're not invisible. Nothing hurts more than, there's an analogy or that Paul, the writer, and I forgot what Bible verse, what book it's, one of the letters that Paul wrote. He said, lest I preach this gospel and become a castaway myself. Lest we go out and take care of people every day, all day, we neglect sometimes things that we need to do. And how could we do that and not take care of ourselves? So it's very important. We take care of ourselves and we take care of each other. And when we do realize this complex, sometimes it's, starts, we've heard of Munchausen. We've seen the movie Backdraft. We've seen where people jump in, they want to save the whole, and it's like, okay, I understand. We can put things in perspective. What things are realistic for us to do? What things are realistic? Is there an underlying issue with this client, with this individual? Is there underlying issues? Is there something that we're not seeing? Is there missing pieces to the puzzle that we're not putting together? And sometimes the social worker is overwhelmed, or maybe, and I'm just using a social worker as an example because in my eyes, I always thought that sometimes case management and their overload with all the inter and outer, pulling the strings, being the liaisons person, just as their name, So a lot of times I would want to reach out and say, well, is there a change in this, that we're doing? Is there something that we can do to lighten it, lighten that load? Maybe residential can come in, and maybe residential will take that person to their court date, or take that person to take that, have that visit with their family. Maybe we'll send an Uber, and the Uber will bring that person to the facility. Would that be better? Oh, the person doesn't want to come to the facility. Or maybe the neighborhood, the person is not comfortable with going to that neighborhood. Maybe we can, you think that we could meet somewhere, like meet at a restaurant, a fast food restaurant? Would that be a little easier? Would that, or meet somewhere quiet, or that would, still give that person their privacy? We wouldn't, be crossing any HIPAA lines. We still would be giving that person their dignity. So there's things that you can think of, different resources. It's very important that you reach out to the team, see what's going on, see what, how are you feeling? What's going on today? Sanctuary, how are you feeling? What is your goal? And not only that, for us to see what areas maybe I may be struggling with. This may be difficult for me right now. I'm having a hard time with this person. I'm having a hard time with this case. Maybe this is, like you said, a trigger for me. Seeing someone go through that, maybe that's a trigger. Maybe it's, I've reached a wall here, and there's times in therapy, people, it's not 1, 2, 3. Sometimes in therapy, I've seen where we have syndromes where people, I don't know, some are familiar with this syndrome where the person they have a nail in their head. but they cannot see the nail in their head, but everyone else can see the nail in their head. When they enter the room, there's a nail in their head. You can hang things on a nail. The only time they see it is when it obstructs the things that they see. And sometimes they'll even move the object out of the way and just walk around with this nail on their head. And it's like, sometimes you get to that place in therapy where it's like, okay, well, let us meet you where you are, because you don't want to get help. You don't want to change the behavior. And unfortunately, circumstances will change your behavior. And those are the times that you feel awful, when you can't really help that person, when you can't really answer them, but you can answer the needs around them, where you say, okay, well, we're going to discharge you now. What does home look like? What does school look like? What does working outside of this look like? What are other relationships looking like? We've reached a wall in therapy. We can't really go any further. You kind of shutting down and giving that person an option to reach back out if they need to, and supporting each other. The support is so important to support each other. It's not your job to fix your coworkers, but it's definitely your job to support your coworkers. That's why we refer to it as a team.
Wow. So this has been a great discussion. I'm so pleased to have you. I'm actually looking forward to us having some more conversations like this in the future. Again, this conversation was about identifying how we can really prevent savior complex. So again, setting boundaries, self-care, seek support, and reflect on your motivations. Okay, so we do this as a team, just like what you said. So therefore, we don't have to feel like we're the one holding everything. We have our teams, we have our resources. Tap into your resources, and more importantly, understand you cannot pour from an empty cup. We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com. or visit our websites, www.advancednurses.info or www.acd4n.com.